This week we'll be learning about the diagnosis of depressive disorders. There are several screening questions you may want to consider, according to Alan Francis. Do you ever get so depressed that you can't function? Or are you almost always depressed? Do you have lots of psychological and physical symptoms occurring around the time of your menstrual periods? And might your depressions be related to your use of alcohol, drugs, or medications? Please tell me about your medical illnesses and their treatment. Diagnosing depression is not always straightforward as it may seem because of the heterogeneity of its presentation. Rollo May, an American psychologist, humanist, and existentialist who has written many influential books such as Love and Will, Man's Search for Himself, and The Cry for Myth, suggested that depression is the inability to see or construct a future. Think about that for a moment. If there's no future, then there's no expiration date on suffering. There will never be another sunrise to blast away the darkness. This is why clinical depression is so intense and overpowering. A person suffering from clinical depression once told me, "It seems eternal, and in its eternity is its meaninglessness and hopelessness." Depression is, in fact, hopelessness incarnate because the hopelessness is literally embodied in the flesh. It is felt in the whole body as well as the mind. I would also add to Rollo May's statement from the previous slide that depression is also the inability to reconstruct a past. Going back to what the individual with depression said, when I'm in a deep depression, there's nothing but right now. There never was a time when I wasn't depressed, and there never will be a time when I am not depressed. This means that my suffering is timeless. All I have is the present, unchanging, never-ending moment. All I have is right now. And in this now, I'm struggling to find reasons to stay alive. The DSM-5 recognizes two broad types of mood disorders: those that involve only depressive symptoms and those that include manic symptoms. Those are bipolar disorders. This week, we will be describing the signs of depression and looking at the formal criteria for diagnosis of the depressive disorders. In a later unit, we'll take a closer look at bipolar disorders, including bipolar 1, bipolar 2, and cyclothymic disorder. The DSM-5 includes many changes, and it includes the disruptive mood dysregulation disorder, a newly defined depressive disorder, and premenstrual dysphoric disorder, which has been moved from the DSM-4 appendix on conditions for further study to the main diagnostic section. And we'll also look at disruptive mood dysregulation disorder, a diagnosis specific to children and adolescents. The cardinal symptoms of depression include profound sadness and or an inability to experience pleasure. Most of us experience sadness during our lives, and most of us say that we are depressed at one time or another. But most of these experiences don't have the intensity and duration to be diagnosable. When people develop a depressive disorder, their heads may reverberate with self-criticism. And one author, William Styron, wrote about his depression. "Like anyone else, I've always had times when I felt deeply depressed, but this was something altogether new in my experience. A despairing, unchanging paralysis of the spirit beyond anything I had ever known or imagined could exist." Physical symptoms of depression are common, including fatigue and low energy, as well as physical aches and pains. These symptoms can be profound enough to convince a person that they must be suffering from some serious medical condition, even though the symptoms have no apparent physical cause. Although people with depression typically feel exhausted, they may find it hard to fall asleep and may wake up frequently. Other people sleep throughout the day. They may find that food tastes bland or that their appetite is gone, or they may have an increase in appetite. Sexual interest disappears. Some may find their limbs feel heavy. thoughts and movements may slow for some. This is referred to as psychomotor retardation. But others cannot sit still. They pace, fidget, and wring their hands, referred to as psychomotor agitation. Some clinicians refer to these physical type symptoms as vegetative signs. Beyond these cognitive and physical symptoms, initiative may disappear. Social withdrawal is common, as many prefer to sit alone. Some people with depression neglect their appearance. And when people become utterly dejected and hopeless, thoughts about suicide are common. As Alan Francis indicates in his text, depressive disorders wear many faces. Consequently, there are numerous diagnoses you need to consider, including major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance-induced depressive disorder due to another medical condition, and unspecified depressive disorder. Now, I've constructed here a very simple flow chart, very similar to the ones you'll see in the DSM-5, which will be very helpful to you in determining a differential diagnosis. Now, if you have predominant symptoms of depression, you want to consider whether or not there is a history of mania or hypomania. If so, this would lead you to be considering one of the bipolar disorders, and we'll be covering those in a later unit. Otherwise, you would be led toward one of the depressive disorders, which may include major depression. These are severe symptoms for greater than or equal to 2 weeks. Dysthymia, chronic depression, which has been lasting for greater than or equal to 2 years. And finally, bereavement, when we'll be discussing this exclusion to the depressive disorders, which involve a recent loss. There are gender differences in depression. Major depression occurs about twice as often in women as in men. This ratio does not hold true in some cultural groups, however. For most ethnic and cultural groups, a clear gender difference emerges during early adolescence. Research has focused on hormonal factors that could explain the vulnerability for women, but other factors may help explain this gender difference. Twice as many girls as boys are exposed to childhood sexual abuse. As adults, women are more likely to be exposed to chronic stressors, such as poverty and caretaker responsibilities. The acceptance of traditional gender roles among girls may intensify self-critical attitudes about one's appearance. And women more commonly focus on gaining approval and closeness within interpersonal relationships, which may intensify reactions to interpersonal stress. In all likelihood, gender differences in depression are related to multiple factors. In considering these issues, bear in mind that men are more likely to demonstrate other types of disorders, such as alcohol and substance abuse, as well as antisocial personality disorder.
When diagnosing and classifying depressive disorders, an important aspect is to ensure the patient has never experienced an episode of hypomania or mania. This may require getting some additional information from loved ones or a significant other. This helps differentiate between bipolar and depressive disorders. With bipolar disorder, the traditional treatment involves the use of lithium carbonate, and studies have shown that lithium is effective in treating mania. Also, consider severity and the chronic nature of the symptoms. Sometimes you will see a specifier after major depressive disorder, indicating whether it is a single episode or recurrent. The DSM-5 diagnostic guidelines for major depressive disorder require impairment in functioning for most of the day and nearly every day for 2 weeks or more. And you need either of the first 2 symptoms I've posted there, depressed mood, sadness, or emptiness, or loss of pleasure in previously enjoyed activities, and you may have both, plus at least 4 additional changes in functioning, including alteration in weight, atypical sleep patterns, restlessness, low energy, feelings of worthlessness, difficulty concentrating, or preoccupation with death or suicide, which clinicians call suicidal ideation. With major depressive disorder, there's also a cognitive component. Aaron Beck identified three types of negative thoughts associated with depressive disorders. The cognitive triad involves dysfunctionally negative views of oneself, the world, and the future. And actually, this is an excellent assessment tool. Simply ask the client how they feel about themselves, then the world, and then the future. And you rather quickly get an idea of their cognitive state. Research has linked a pessimistic explanatory style to depression, where individuals internalize the cause of an event and believe it is due to some internal flaw. People who tend to blame themselves for negative events believe these bad things will continue indefinitely and affect all aspects of their lives. Here's a diagram of Beck's cognitive triad and examples of what someone might say. Starting with their self-view, you clearly see it is negative. I am worthless. Now this becomes a negative downward spiral. People think negatively, so their mood is negative, and they don't engage in an activity or behavior that might cheer them up. Then they think they're worthless because they didn't do anything, and they feel even worse. Behavioral interventions would identify some things they might do to improve their mood. Cognitive interventions would involve challenging these negative beliefs and changing these self-talk messages. Some individuals with major depressive disorder and bipolar report a seasonal pattern to depressive episodes. Now, these symptoms are associated with changes in daylight as the seasons change. This occurs more often in northern latitudes. It was previously termed seasonal affective disorder. Seasonal affective disorder is no longer considered a unique mood or depressive disorder. Now a specifier with seasonal pattern is used for recurrent major depressive disorder that occurs at a specific time of the year and fully remits otherwise. DSM refers to this as major depressive disorder with a seasonal pattern. Clinicians are cautioned to differentiate between normal grieving associated with a significant loss and a diagnosis of a mental disorder. While the grieving process is natural and unique to each person, grieving can look like symptoms of depression, with intense sadness and withdrawal. Grief and depression are different in important aspects. In grief, painful feelings come in waves, often intermixed with positive memories of the deceased. In depression, mood and ideation are almost constantly negative. In grief, self-esteem is usually preserved. In major depressive disorder, corrosive feelings of worthlessness and self-loathing are common. While many believe some form of depression is a normal part of bereavement, major depressive disorder should be carefully diagnosed because of the possibility of labeling a normal reaction as a disorder. For some people, the death of a loved one can lead to major depression. Another diagnosis in this category is persistent depressive disorder, which used to be called dysthymia. The symptoms are present most of the day for more days than not for a 2-year period, with no more than 2 months symptom-free. 2 or more of the following symptoms must be present: feelings of hopelessness, low self-esteem, poor appetite or overeating, low energy or fatigue, difficulty concentrating or making decisions, sleeping too little or too much. Despite the fact that people with this disorder do not experience all the symptoms of major depression, they are never free of their symptoms for more than 2 months. It is a low-grade, chronic, persistent depression and is not episodic like MDD. The symptoms of dysthymia cause distress but are not as severe as the symptoms of major depressive disorder. Symptoms of MDD have a sudden onset and they impact daily functioning.
Due to the concerns over the potential for overdiagnosis of bipolar disorder in children, the authors of the DSM-5 added a new diagnosis, disruptive mood dysregulation disorder for children 6 to 18 years of age. Age of onset must be before 10 years of age. Research has found that there's some evidence that these children typically develop unipolar depression or anxiety as they mature. This disorder is characterized by chronic and severe irritability and frequent temper tantrums that occur on average 3 or more times a week over at least 1 year and in at least 2 settings. These outbursts are developmentally inappropriate. Between outbursts, children with this disorder are extremely angry or irritable. The criteria specify that the diagnosis should not be assigned to children whose first episode occurs when they are younger than 6 or older than 18, and onset must be before the age of 10. Children presenting to clinics with this disorder are predominantly male. As with all depressive disorders, it is important to evaluate for suicidal risk, suicidal ideation, and aggressiveness. Extremely low frustration tolerance results in dysfunction at school and in family and peer relationships. Severe disruption in the lives of the affected individuals and their families occurs. This particular diagnosis has been particularly controversial among clinicians because of the extreme importance in evaluating for a differential diagnosis. Typically, there are complicated histories. Many meet the criteria for other disorders as well. The rates of comorbidity are extremely high. Differentiation from bipolar and oppositional defiant disorder is emphasized by the DSM-5. Bipolar disorder is detected by the discrete episodes of a manic or depressive episode, which indicate a change from the child's usual mood. The presence of severe and frequently occurring outbursts and a persistently disruptive mood between outbursts may warrant the additional diagnosis of ODD. Only about 15% of individuals with ODD would meet the criteria for disruptive mood dysregulation disorder. Alan Francis stresses this diagnosis is based on minimal research and was justified only by the need to reduce overdiagnosis of childhood bipolar disorder. See pages 47 and 48 of the text, Essentials of Psychiatric Diagnosis, for further information.
The final depressive disorder we'll take a look at is premenstrual dysphoric disorder, and it was a controversial one added to the DSM-5. This involves serious symptoms of depression, irritability, and tension appearing the week before menstruation, and they remit soon after the onset of menses. At least 5 symptoms must be present: significantly depressed mood or mood swings, anger, irritability, anxiety, tension, difficulty concentrating, social withdrawal, food cravings, insomnia or excessive sleeping, feeling overwhelmed, and a lack of energy. This diagnosis was in the appendix of the DSM-4-TR, and at that time it was not diagnosable, but was being studied. And the DSM-5 authors have now made this a diagnosable condition. This diagnosis was controversial in the task force committee meetings because critics say this diagnosis, PMDD, pathologizes the normal monthly variations in mood that women may experience. However, the counter-argument is that a majority of women do not experience severe mood alterations on a monthly basis. By including PMDD as a diagnosis, women with these symptoms can now receive treatment that might not be otherwise available to them. The text applies the multipath model to discuss how biological, psychological, social, and sociocultural factors interact to cause depressive disorders. These are complex interactions which become apparent when looking at the biological dimension. Low levels of certain neurotransmitters, including norepinephrine, serotonin, and dopamine, are associated with depression. Depression tends to run in families, and the same types of depression tend to be found in families. So there is evidence of genetic transmission. Genes interact with the environment and stressors. Chronic depression may occur because of a short allele of the serotonin transporter gene. Consequently, there's more of the stress hormone cortisol released. If this allele is longer, there appears to be more resistance to depression. The overproduction of stress-related hormones, such as cortisol, appears to play an important role in the development of depression. The stress circuitry in the brain, remember the HPA axis, controls the release of stress hormones. And research has shown that people with depression have higher levels of cortisol, which may be related to genetics or early childhood trauma. Exposure to stress during early development affects cortisol levels. High levels of cortisol can damage the hippocampus. The neurons in this brain structure die and fail to regenerate. This leads to dysregulation and interferes with the stress system. Our circadian rhythm also appears to play a role in depression, particularly seasonal depression. Circadian rhythms are controlled by internal biological clocks, maintained by the hormone melatonin and exposure to sunlight, which affect a number of biological processes, including sleep patterns. Sleep disturbances are strongly linked to depression. People with depression have irregularities in the rapid eye movement stage of sleep, where dreaming occurs. Insomnia doubles the risk of depression. Excessively short or excessively long sleep doubles the risk of depression. Cognitive psychologists say that depression is caused by the way people think, and negative thoughts result in pessimism, damaging self-views, and feelings of helplessness. There is a phenomenon called learned helplessness, which is a belief that one is helpless and has little influence over what happens. This is associated with a negative attributional style, which focuses on causes that are internal, stable, and global. For example, if something distressing occurs, like being turned down for a date, the person might think that it is their fault. They will always be turned down, and that it will affect all aspects of their life. Rather than seeing external causes, someone with a negative attributional style sees personal factors as the cause. In the psychological dimension, behavioral explanations suggest depression occurs when people don't get social reinforcement. So behaviorists identify variables that can increase or decrease positive reinforcement. Participating in few potentially reinforcing activities. There may be few reinforcements available in the environment, such as living in an isolated area. Or the individual's social skills and behavior may limit or increase opportunities for positive reinforcement. People who are depressed interact with others less, and the depressed appearance makes it less likely that others will interact with them. In treating depression, often medications are used. Antidepressant medications increase the availability of certain neurotransmitters in the brain. Some types that are used are SSRIs, which increase the availability of serotonin in the brain. The brand names are Celexa, Lexapro, Prozac, Paxil, and Zoloft, for example. Now, there have been concerns with sexual side effects and other side effects, including possible increased risk of suicide. Another type are the SNRIs, the selective serotonin norepinephrine reuptake inhibitors. They increase the availability of two neurotransmitters. The SNRIs appear to have overcome the sexual side effects. Bupropion is another type, and it's a norepinephrine dopamine reuptake inhibitor with the brand names Wellbutrin and Zyban. Now, the choice of drug to begin with tends to be based on the experience of the physician and the patient's ability to tolerate side effects. Family doctors prescribe most of these drugs, and I've sometimes been contacted to consult with the doctor on these medications. It takes anywhere between 2 to 6 weeks for antidepressant medications to have an effect on a person's mood. Psychological and behavioral treatments for depressive disorders include behavioral activation therapy. Here, the idea is to identify and then do things you enjoy. The goal is to actively engage in life. It seems foreign to people in this culture because we often wait to feel better to do things. The idea behind behavioral activation therapy is to do things to make you feel better. Cognitive behavioral therapy focuses on altering negative thought patterns, like Beck's 6 types of faulty thinking. Therapists help clients identify thoughts associated with depression, help them distance themselves from these thoughts, and examine the accuracy of their beliefs. This is a powerful treatment method, as individuals treated with CBT are less likely to relapse than those treated with antidepressants.